Well, good morning, good afternoon, and good evening, wherever this may find you. Welcome to this webinar. My name is Dr. Jerome Gallia, and on behalf of the co-chairs of the Union TB and Mental Health Working Group, Dr. Annika Sweetland and Dr. Sangak Shin, I welcome you to this World TB Day 2021 webinar entitled Integrating TB and Mental Health Services to End the Epidemic. We are so glad that you took the time out of your schedule to join us today. And I'm particularly thankful of the support from UC Irvine for hosting in this webinar and the technical support they're providing today. I would also like to say that while you're joining us, you may notice that your audio has been muted to eliminate the background noise and interference. That's because this webinar is being recorded to be able to share afterwards. So we do ask that you submit your questions for the speakers using the chat function that you should see on your end. Even though we've muted you, that doesn't mean we don't want participation. It's easier if we read it in text, and we'll be answering those questions there. So thank you so much. And because this webinar is limited to just an hour, I'm not going to spend much more time discussing logistics, and instead move right into the presentation. We're going to begin with a presentation by Andrew Basham, who's a Ph.D. candidate from the University of British Columbia, Canada. And he'll be providing a short presentation entitled An Overview of Systematic Reviews with a Focus on Depression. Let's move to this presentation.
Thank you for having me here today. It's an honor to present to you TB and mental health, an overview of systematic reviews with a focus on depression. Some big questions about the relationship between TB and mental health that guided the literature review for this presentation, and which my presentation will follow as an outline. Is depression higher in TB patients? Systematic review of depression in the general population found a pooled prevalence of 13%. While a systematic review of depression prevalence in TB patients found a pooled prevalence of 45%. Based on these figures, TB patients have 3.5 times the prevalence of depression than the general population. Does depression increase the risk of negative TB treatment outcomes? In short, yes. Few studies are published, but they are consistent. Depression among TB patients is associated with 4 times the odds of negative TB treatment outcomes, such as death, loss to follow-up, or non-adherence to TB medication. And the results of those studies are presented in the forest plot on the right. Does TB increase the risk of depression in non-depressed persons? Cohort study from Taiwan by Shen et al. Found a 53% higher risk of depression in TB patients compared to non-TB controls. And there's a stronger effect in males than in females, and this effect of TB on depression risk diminished over time, but remained significant at 4 to 6 years post-TB diagnosis. Another cohort study of pulmonary TB patients found a 74% higher risk of depression, and also identified a dose-response relationship between high ethambutol dosage and depression in TB patients. The effects of TB diagnosis on mental health may extend beyond TB patients to their close contacts. A study of TB contacts by Pan et al. Observed a 34% higher risk of depression in female contacts than female controls, and a 37% higher risk of depression in low-income contacts than low-income controls. Multi-drug resistant TB can have particularly devastating impacts on mental health. In a systematic review by Thomas et al., Isaacides noted that patients voiced concerns about stigma, depression, hopelessness about the efficacy of treatment, guilt due to lack of work productivity, lack of emotional support, and the perception that the side effects of medication cause greater suffering than the disease. Some quantitative observations. Vega et al. Observed that 13% of MDR-TB patients developed depression, while 12% developed anxiety and 12% developed psychosis. Furin et al. Noted that 18% developed depression, while 12% developed anxiety. Are comorbidities associated with depression in TB patients? Comparison of TB patients with and without comorbidities from a study in Africa found the following associations. TB patients with 3 or more comorbidities had a 35% higher odds of psychological distress than TB patients without comorbidities. TB patients with 1 or more comorbidity had 36% higher odds of PTSD, while 2 or more comorbidities was associated with 76% higher odds, and 3 or more comorbidities was associated with 63% higher odds. Some strategies for improving mental health in TB care include screening for depression during treatment. With 45% of TB patients depressed at diagnosis, a high yield of depression is likely. Linking to appropriate care and support is possible only when depression is identified. Integrating mental health into TB services. This is a goal of the NTB strategy, and there's political will to do so, with 92% of TB program directors surveyed by Sweetland et al. Reporting that they were somewhat or very receptive to TB mental health integration, and 65% reporting that it was very likely to happen. Managing comorbidities among TB patients during treatment. The more comorbidities a TB patient has, the more likely depression is. TB treatment may be an opportunity for linking TB patients to primary care or chronic disease management programs, particularly if access to primary care is difficult. Finally, research on mental health prevention, diagnosis, and care for TB patients and survivors is needed. There are many unknowns in terms of prevention and management. Epidemiological, health services, and intervention studies could help elucidate pathological mechanisms, current care patterns, and effective interventions. Qualitative, quantitative, and mixed methods approaches that involve TB survivors may together help us address the TB depression syndemic. My references are available here, and I'd like to thank you for having me, and feel free to reach out to me via email or Twitter.
Thank you so much, Andrew. That was a really succinct, dense but comprehensive review, and a really great way to start off today's webinar. And right on time, too. Isn't that great? And I can already see Dr. Sweetland is queued up and ready. So without further ado, it is my great pleasure to introduce Dr. Annika Sweetland, who's Assistant Professor of Psychiatry and Public Health at Columbia University. She's one of the co-chairs of the TB and Mental Health Working Group from the International Union Against Tuberculosis and Lung Disease that I mentioned earlier. And her presentation is integrating evidence-based depression treatment into primary care in the TB control program in Brazil. Dr. Sweetland.
Thank you, Dr. Gallia. I'm very pleased to be here today. Good morning, good afternoon, good evening. I wanted to begin very quickly with an overview of sort of a timeline of the TB and mental health movement towards integration, beginning with when the TB and Mental Health Working Group was started in 2014. At that time, there was very limited literature, a few studies here and there documenting an association between TB and mental health, but it really was a little bit spotty, methodologically weak, and there was a strong need for more evidence and evidence base. In 2015, the WHO TB program, the NTB strategy, was the first time they explicitly mentioned the need for mental health integration to reach the NTB goals. In 2016, the WHO mental health program released the second intervention guide for mental health interventions that are brief, low cost, can be delivered by non-specialists in primary care settings. And so really the toolkit for how we can address mental health disorders in primary care. And then over 2017, 2018, our group conducted a global survey that Andrew just mentioned, where we interviewed, if you could press tab again, we interviewed 26 countries, the national TB program directors, mostly high burden countries. And there was a very high receptivity to integrating if such tools, if such interventions like the ones in MHGAP were available, if training were available, if there were capacity, what's the likelihood this could be integrated into the national platform? And there was very high receptivity. So there's political will. And then finally in 2020, Andrew, or building up until now, a number of systematic reviews and meta-analyses have been released that have fully established and documented without any doubt there is a very strong link between TB and mental health, and that it's associated with all negative TB outcomes, and there's a great need to address this. So the presentations that you're going to see today are 3 case studies. I'm going to talk briefly about a pilot study I conducted in Brazil. And Aneeta Pasha is going to describe another intervention in Pakistan, and Carmen Contreras is going to describe one in Peru. All of us were using interventions recommended by MHGAP. So really starting to address the question of how can we take these evidence-based interventions and integrate them into existing platforms. Next, please. And really, my study is an implementation science study. So it wasn't looking at effectiveness. It wasn't looking at it wasn't looking at how to improve the outcomes. It was looking at, or how much the effectiveness of improving outcomes. It was about the how of how to do it. So the study took place in Itaboraí, Brazil, a city of about 240,000 people just outside Rio de Janeiro. The program is in Brazil. The primary care system is decentralized, meaning all the primary care happens at the household level, and little teams of primary care providers, doctor, nurse, community health workers are in charge of catchment areas of about 3,500 individuals. That said, if you could press tab twice, there's 38 primary care teams located throughout, you can see with the green dots, and the TB program as an infectious disease program is centrally located. So individuals, when they develop symptoms, are referred from the primary care facilities to the centralized program for testing and for monthly monitoring, but the day-to-day care happens at the primary care level. Next, please. Next. Oh, the animation, sorry about it, it's a little bit difficult. So what we did is we decided to, we identified 3 pilot sites to integrate an intervention called interpersonal counseling. Interpersonal counseling is a brief version of interpersonal psychotherapy, one of the MHGAP interventions. And we chose these 3 sites as 2 primary care facilities located in the periphery and the TB control program to see how we could best do this. Next. We began with some focus groups, looking at, really the how. So where should it happen? Who should be doing the service? Should it be doctors? Should it be nurses? Should it be at the household level? Should it be in the clinics? Should it be, all those how, when, why, where questions. And we did 6 focus groups with health providers from each of these pilot sites, as well as health program coordinators at the system municipal level, and with some current and former TB patients. And what we found was a series of barriers and facilitators. If you could, yeah. So the barriers, if you can just highlight all of them. The barriers we found were, poverty in general. When we did these focus groups, it was during a moment of extreme political crisis. The 1 month prior to the focus groups, the president of Brazil had been impeached. During this time, 30,000 people in the city of Itaboraí lost their jobs because of the oil refinery that was caught up in that political scandal, which is located in Itaboraí. The health workers had not been paid for 5 months, and yet, and so there was a huge need for mental health services. And despite the fact that the system was totally overburdened and the health workers had very high levels of distress, there was very strong receptivity to doing this. They wanted to learn about mental health. They wanted to address the needs of the communities. So that was very exciting. So it's both a barrier and a facilitator. The facilitators, if you can highlight all of them, is that again, that there was very high need, that there was a high level of community trust because of the primary care system that's outreach level at the household level. There's a high trust with the people who are in the primary care system closest to the ground. And there was an acceptability of this approach where different types of primary care workers could be trained to deliver the intervention. And importantly, as an implementation science study, what we did was we didn't say in advance, we're going to train the community health workers or we're going to train the doctors. Instead, we opened it up to anyone who wanted to be training, to be trained, and actually every single person that was offered to be trained accepted. And there were 36 providers, primary care providers of all levels, from the administrators up to doctors. And about a third of the people who were trained did go on to implement the intervention over the course of the next year. Next, please. One important thing to note is that of the 3 sites in which we went to implement, one of the sites was not successful at all. So within the first 2 months, they decided not to implement at all. The problem in that setting was that there was a lot of violence in the community, and we couldn't come up with a safe way for the clinical supervision to take place. We had intended it for it to be in person, but it was not safe for our clinical supervisors to go there. The connectivity was not good enough to do virtual supervision. So that site in the end didn't work. That said, the other 2 sites were highly successful and had, this cadre of mental health champions that sort of self-selected. And this included community health workers, nurses, doctors, so people of any different level, that really the commonality between them was like motivation to do this, and a certain sort of personality profile that made them disposed to do this kind of, to do the work. Not everyone is born to be a therapist or wants to be a therapist, but there's certain people who are very motivated, and they did a really wonderful job. So it was 39 supervisions over the course of the year with a TB program, 37 in Visconti, one of the primary care facilities, and only 2 in the one clinic where real world complex problems interfered with the ability of them to implement. The other challenges were that after the training, there was a staff rotation. So some of the people that we had trained rotated out. Yeah, so next, please. We did, at the end of the 1 year, we did a training of trainers. So the people, those champions who had revealed themselves, we trained them to do supervision and to train others. Then we supported them to do their own training of providers in the community. So basically leaving that capacity at the city level. Next, please. And after the course of the year, we conducted 7 focus groups. This data is still being analyzed, so I'm going to give you a very vague sort of overview of what we found. If you could list the first few findings. The facilitators that we discovered is basically, this was a very acceptable and feasible intervention. There was a very high, they loved it, essentially, those who decided to conduct it. And it wasn't a clinical trial, so we don't have strict clinical data, but we have some anecdotal data, which was that of the 43 patients that completed 43 patients who were offered the intervention, 80% of them completed all 4 sessions, which is pretty remarkable. 2 patients required 1 booster session, and of those, 97% of those 80% that participated achieved full depression remission. So although it wasn't a clinical trial, it showed very high promising effectiveness. And the PHQ-9, which is a depression screening tool that we used, it really helped to facilitate referrals from primary care to specialized care services when necessary. And so that was another of the findings. In terms of barriers, we found that there was still a lot of violence, the work overload, the staff rotation. These were big challenges. These are real world challenges. When we go to implement at a city level, I think it's not possible to start with a few clinics. I think you have to start with the whole network so that when people rotate, they still have capacity. We were not able to, during the course of the pilot, engage the mental health program for any number of reasons at the time, politics. So we ended up, it was really spearheaded by the TB program and the primary care system and the mental health specialized care services really didn't want to engage in the pilot. That said, at the end of the pilot, they expressed a lot of interest in becoming involved in the next phase. So, that'll be great when we do the next the next phase of it. The cost of supervision was a concern in terms of sustainability, because bringing our 2 supervisors in person to each clinic once a week is not a sustainable, replicable model. That said, right at the end of after the end of the pilot happened, COVID happened, and now there's a lot of creativity about how the supervision can be done remotely now, hopefully in a sustainable way. So when this is implemented in the future, we'll be able to hopefully address that issue. And then fidelity to the intervention. So that's the degree to which the providers are actually definitely implementing the intervention as described in the manual. We didn't supervise that closely, that we were able to monitor it through the clinical supervision, but that's going to be a challenge moving forward. And so that's a brief summary of the pilot study. Acknowledgements, many collaborators in Brazil and the US made this study possible. Thank you. I'm looking forward to hearing the other 2 case studies, which did other similar interventions recommended by WHO in very different contexts, and excited for us to be building this evidence base on how to integrate TB and mental health services in complex, low resource settings. Thank you.
Thanks so much for that great presentation, Annika, and right on time too. It's a lot of information to cover. It's really exciting work that you're doing. Let's zip across the globe then and move to Pakistan. We're going to be hearing from Aneeta Pasha, the country director and director of mental health at the well-known organization IRD in Pakistan. And Aneeta will be presenting on the impact of integrating mental health services within existing TB facilities in Pakistan. Aneeta.
Hello. Sorry, just there. Thank you so much. I'm so excited to be here today and hear all of this excellent work, and very interesting. And I'm so glad that there's a whole movement now towards this work. So today I'm going to be talking about our work in Pakistan in integrating mental health services within existing TB facilities. Before I begin, just very quickly, a little bit about IRD. We are a public health research and service delivery organization that started out in Pakistan, but now we have programs in over 9 countries across the globe. And if you see at the top, these are the various disease areas in which we currently have either research or service delivery programs. And TB has been one of our flagship programs that we started out with very early on. I'm going to be talking about the mental health program, which I started at IRD in 2014, and it is based on a task shifting model. So using community health workers, community counselors to be able to provide a frontline therapy for depression and anxiety. In Pakistan, though, of course, just to give you a little bit of context, Pakistan is the 5th highest TB burden country in the world. We have over 500,000 people falling ill with TB annually. In 2019, there were about 44,000 deaths by TB. And just so we know that TB is a really important critical problem in Pakistan, but at the same time, mental health also is a really critical issue. We have about a prevalence of depression and anxiety around 34% in the entire country. It's a higher prevalence with women, around 66%. So really an important problem that we need to address. And then when we combine TB patients and mental health issues, obviously it becomes even more critical. So the objective of our study was to evaluate whether integrating mental health services within existing TB treatment programs has an impact on not only mental health, but TB treatment completion as well. Our study was funded by the Harvard Medical School Center for Global Health Delivery in Dubai. So what we did is, as I said, we had our core component of our program is the training of lay counselors, community counselors. We take them through a basic counseling skills training using CBT and problem solving therapy. It's about 6 to 8 days the training. And then they have monthly refresher sessions and monthly learning sessions. And then at six health facilities in Karachi, 3 public and 3 private, is where we established integrated practice units. So these are places where there are existing TB treatment facilities, and then we integrated the mental health intervention as well. The community counselors were screening DS-TB patients for symptoms of depression and anxiety using a locally developed tool, which is the Aga Khan University Anxiety and Depression Scale. It was locally developed in Pakistan. It's a 25-item questionnaire. The score goes up to 75. So any of the patients who scored 21 or greater than 21 on the score are asymptomatic, and then they were provided 4 to 6 counseling sessions, which is the mental health intervention. And at the end of their sessions, we rescreen them using the AccuAds. As I said, what we were interested in looking at is the impact on mental health. So we assessed the differences in their scores pre-post intervention, but also we then compared the TB treatment completion levels for those patients who received the mental health intervention compared to those who did not receive the mental health intervention. And for those who received it, we looked at the number of counseling sessions that they went through and the correlation to TB treatment completion. So in totality, we screened 3,500 patients for depression and anxiety. Of these, we found a symptomatic rate of 30%. And of those, we initiated about 96% on the mental health intervention itself. And of those, about 50% completed the mental health intervention. So just looking very quickly at the results, we saw an average drop of 16 points on the pre-post AccuAd score. And obviously, as I had mentioned, people who had less than 21 were no longer symptomatic. So in totality, 52% of our patients no longer reported any symptoms of depression and anxiety once they had gone through the entire intervention. What is a critical finding in our study is that the individuals who are symptomatic for depression and anxiety who completed the mental health intervention had a higher rate of TB treatment completion. So this would be the patients who had less than 4 sessions, counseling sessions, had a TB treatment completion rate of 75% compared to those who had 4 or more sessions who had a TB treatment completion rate of about 93%. So this was one of our most significant findings in the study. And going back to what Andy had presented and Annika had presented, kind of supports what the other literature is saying as well. What we also found that was of interest was that each subsequent counseling session led to an increase in TB treatment completion. And the greatest proportionate of increase came at about 4 sessions. So the first session, if you look at the graph, it's about 73%. People who did the second session, third session, it would subsequently go higher. But people who had completed 4 or more sessions had TB treatment completion rates in the 90s, which again is something that's really significant from a programmatic point of view. So finally, our study showed that providing mental health counseling services to TB patients has a significant impact on TB treatment completion rates. And also in a context like Pakistan, where there is a shortage of mental health service providers, we know that the lay counseling model of having community counselors integrated within TB programs can be a low-cost, efficient, quick way to bridge the treatment gap for mental health. So thank you. I'm looking forward to any questions. We are hoping to publish this study very soon. And so I'd be happy to share that with everybody once it has been published.
Thank you so much. What an excellent presentation, and really made me think. We all believe that mental health is a human right and should always be offered with, in any collaborative care model. And this presentation really took it to the next step and said, but look at your treatment outcomes are better and people hear better. It's a super, super work. I can't wait to see the questions and read your paper. Thank you so much, Aneeta. Well, from Pakistan, we now cross the globe again, headed this time to the great country of Peru, Lima, Peru, where we'll be hearing from Carmen Contreras, who's the director of the mental health program for Partners in Health Peru, or Socios en Salud, as it is locally known. Carmen is also an esteemed Harvard Lead Fellow with the Harvard Global Health Institute. Carmen's presentation today is entitled Integration of a WHO Low-Intensity Depression Intervention with TB Treatment in Peru. My good friend Carmen, please take it away.
Thank you. Thank you very much. I will try to have some information. My name is Carmen Contreras. I am working in Socios en Salud. Socios en Salud is one institution that are working in mental health program. Thank you, Jer. The next, please. The mental health program. Next, please. Thank you. Yeah, is working in Peru. The population in Peru is close to 30 million of people. The overall depression prevalence is 20%. And the prevalence in persons that are affected by TB is close to 46%. We are having 30,000 and 40,000 cases per year, approximately. The major comorbidities are tuberculosis, diabetes, hypertension, and malnutrition. The high problems, the social economical problems is unemployment rates, crime, migration, most internal migration. Next, please. In Socios en Salud, we are working in different programs. When we start our work in Peru, we start with TB projects in 1996, but then we are moving to another projects like child caregiver from 6 to 24 months in 2016, and then we are moving to maternal projects, pregnancy mothers with depression. And then lastly are in chronic mental disease like to schizophrenia, because you know that we are a lot of problems with persons that are living with schizophrenia in the community. Next, please. This is the totality of projects that we are working at the moment. This is my team. The next, please. A little data for tuberculosis in Peru. You can see the last report from the Ministry of Health in 2020. We are having 41,000 persons affected by TB. The majority are in Lima. According to the sex, 64% are male. And the Minister of Health say that 1 in 4 people are infected with TB, and 1 out of every 1,000 people is sick with TB in all the forms. Next, please. More data about TB is 5 regions in Lima are having high incidence in TB. Lima and Callao report the majority of cases, 60% of total TB case, 78% of all MDR case, and 77% that all the XDR case, and the comorbidities with HIV are very high too. 58% in Lima and Callao, 6% of all persons that are affected by TB are having HIV too. And of them, 61% in population between 30 and 59 years old. Region. The next, please. And about that. Next, please. We are having problems with depression. close to the half of patients with TB are having depression, a little more anxiety, stigma, discrimination, episodes of violence and trauma. And all these problems, the mental health problems, reduce the adherence to the treatment. Next, please. Now I need to tell about the special project, TB Mobile Project. We start with the strategy of search, treat, and prevent. To do this, we have to change the unit of intervention to the communities. That is to look for people who are sick in the community. Next, please. For this, we developed two mobile units were implemented, which had an X-ray machine. One algorithm was used to identify TB suspicions. A clinical team performed the clinical and bacteriological diagnostic to confirm TB. Everything in the community, like this picture, and the results were ready the same day. And our objective in mental health was to reduce depression in all the participants who have tuberculosis and who were identified in the mobile units. Next, please. For that, we elaborate the pathway of care. You can see the pathway. And the next is the person that they don't have depression, that's it. But the second, next please, is when the person in our tool, PHQ-9, the punctuation is from 5 to 9. We catalogate in minimal symptoms. The next, in this case, we include psychological first aid, only one session. Next, please. Yes, this is our session to psychological first aid. In other case, next, when the person in our PHQ-9 is having 10 to 14 points, we include another strategy. Next, the strategy is about problem management plus. This strategy was elaborated for WHO. Next, when the person affected by TB are having in the PHQ-9 more than 50 points, and if they have antecedents to history of depression, psychosis, drug abuse, we need to refer to another public service. The next, please. This is the picture when we need to refer some patient to public service. And next, and this is our intervention. It was all in mobile units, and we screen for TB. We provide educational support, and then if the person are having TB, we connect with our psychologist to the house, to the health center. Next, I want to tell that we are having two cohorts. The first cohort was before the pandemic, when the community was free, when we connect directly with the community. And the second cohort, the next please, is currently in the pandemical situation. Next, please. We need to wait some months for re-interview another patient with TB. And this is the preliminary results. We include 177 patients that are affected by TB. You can see the results for depression. The next list is according the year. You can see the majority of patients is from 18 to 79 years old, very young population. The next is according by sex. is equal between male and female. And I want to say the last part, the next please, is about our intervention with persons that are having mild major depression. How I say, for this person, we are using problem management plus intervention. Next, please. The objective for that is to help the people that are living in adversity, especially with depression. This is the low intensity psychotherapy rooted in cognitive behavior therapy. And the person that provide this intervention are the psychologists. Next, in the next slide, we can see the structure to PM+. One session is for screen the person affected by TB, and the 5 follow-up session is to provide the psychotherapy support. The next, please, is the results that we are having. We include 12 participants, 6 female and 6 male. You can see that we start the last 3 months in 2019, and we continue in September 2020 until now. And the next slide, and the next slide is about the improvement in depression. You can see when we start the treatment, the mental health treatment, we enroll all the patients that are having mild major depression. But you can see when we continue the psychotherapy until 5 sessions, the depression was remission. And yeah, this is a good experience for us, and we try to continue in all the patients that we identify in the 2 mobile units. The last slide is about our recommendation. It's necessary to provide support to the networks for persons affected by TB, and because it's necessary to fight against the adverse effect, not only for TB, for physical disease, we need to increase the mental health adverse events. And the second is to strengthen the mental health components in persons affected by TB and health worker, and to see the mental health as how it's fundamental, like to physical health. Thank you. Thank you very much.
And what a great presentation. Let me see if I can stop sharing here. There we go. What a great presentation to round up the series. And what I really liked about that presentation, Carmen, is that you're using an existing intervention that was already being used in the country and integrating that with tuberculosis care rather than coming up with a brand new intervention. So there's plenty that we could talk about now, and there's no better time to do that than now. So I'm gonna pass the presentation, the microphone over to Dr. Sang-Hyuk Shin, who will be handling the Q&A portion of the session and lead us up to the top of the hour. Sang-Hyuk.
Thank you. Thank you, Jerome, and thank you to all the speakers and all the attendees. My name is Sang-Hyuk Shin. I'm with University of California, Irvine. I'm at the Sue and Bill Gross School of Nursing and also the director of the UCI Infectious Disease Science Initiative. So I'm going to go ahead and jump in with some of the questions that were posed in the Q&A, and thank you for the panelists for answering some of the questions already. And if for all the attendees, feel free to continue to post questions on the Q&A session if you have any. We'll try our best to get to them. But the first question I had was, and it was addressed in the Q&A box, but I think it bears speaking about this more as a group as well. And so I'd like to pose a question to the panelists about the question of cost and sustainability. And I think that these are issues that have always come up. And it seems like the amazing, it seems like we've definitely made a compelling case that there is a need to address mental health among people affected by TB, and also for that addressing mental health has a beneficial outcome. But there are costs involved, and so can you talk a little bit about sort of the strategies that you think we can use to make sure that there is sufficient investment in mental health counseling and integration within TB care? And I'll pose that to any of the panelists, and maybe with Carmen or Aneeta, if you can start us off.
Sure, I'm happy to start off. So, the issue of sustainability is an ongoing challenge. I think it's an ongoing and one of the biggest challenges with mental health. One of the things that we've done with mental health integration is also integrating it not just in TB programs, but also within primary care in Karachi. So once we did this study, we then extended the same model into primary care settings. And over the last year, we have integrated this with about 75 counselors across the city of Karachi through partners. So these are private primary healthcare providers in Karachi working at the community level, and they've set up clinics through their own funding mechanisms. And what we did when we started that interaction with them was to say that, look, we know it works. Here is the evidence. And making a case for it, but to say we will initially invest in the costs, of setting up mental health services for you in terms of training the counselors, placing them, providing, the technical supervision, the data management support, all of that. But we would ask that after a certain duration, all of these costs are integrated within your own operational costs. So we will demonstrate the impact to you, but, as part of this relationship, we would ask that you do that. And I'm really happy to say that at the beginning of this year, we had all three of our partners, we just had three, all three of them actually be willing to do that. And so we're really excited about the fact that moving forward, we are stepping out of funding those counselors, and they're just getting integrated within those networks and those infrastructures. So the understanding with one of our partners is that what they've been doing is scaling up across the entire country, out of the city, but across the entire country. And wherever they have a primary healthcare center, they make sure that one of the counselors is funded, and we provide the supervision. And so, I mean, that's one of the ways we've tried to work around the issue of sustainability. But as I said, it's ongoing, and it's sort of an uphill battle.
I want to add that it's necessary to strengthen the community, like to TB Mobile. We are working very hard with primary level, and in the community, this is the very important strategy that we are using. But then we are at the mental health support, but this is so interesting because when the people is going to the hospitals, to the other levels, to the health center, it's more difficult to include the mental health. But if we work in the community, it's more consistent. The people in the primary level recognize that the importance to include the mental health support in the patients that are having TB. And in the other hand, PM Plus is a good strategy. When I provide psychological first aid, is only one session, but if you identify another problems like to mild major depression, it's necessary to include more psychotherapy, like CBT. But if the people in the health center recognize that the person is more good, that is more healthy, that is going to the health center to take the medicine, and the depression we can reduce with this strategy, is more sustainable in the communities. And I try to say that it's necessary to move to the community, more close to the people, when they are having problems with TB and mental health problems too.
Thank you.
Yeah, I'd love to just add to that briefly. In the study that I conducted in Brazil, it was in partnership with the municipality of health, so the national TB program, and we trained existing staff. And while there was very high receptivity, there wasn't a lot of bandwidth. They have full-time jobs and are quite busy, so the number of patients they were able to treat was relatively small. And I wanted to highlight a systematic review that came out this last year, 2020, by Cubillos et al. In British Journal of Psychiatry, that looked at the effectiveness and cost effectiveness of integrating mental health services into existing health platforms. And ultimately what they found was that integrating mental health into primary care platforms can improve health outcomes and can yield savings over time. The thing is that it often does require initial upfront investment in hiring additional staff. So that's just something that we need to think about moving forward, especially with TB. I think hiring, say, one additional community health worker, I think for every patient with drug resistance that's averted, with all the deaths that could be averted, with people who stop treatment and remain infectious in the community, there's all sorts of epidemiological benefits of treating mental health to improve the outcomes. And therefore, I believe that we can make in TB this economic argument for why mental health integration needs to happen and why upfront investment is worthwhile to achieve those outcomes.
Thank you. The one, of course, pressing issue that we're all dealing with is currently with the COVID-19 pandemic, and I think the WHO recently released just an alarming stat that an estimated 1.4 million people with TB were not diagnosed because of the pandemic, because of the fear of COVID-19, and because of stay-at-home measures and all of that. So I wonder if the panelists can speak a little bit about how that might impact the mental health issues among people affected by TB, and also your own programs on the ground in terms of trying to provide services to people with TB.
I can go first again. Yeah, absolutely. I think, the lockdowns, the restrictions, all of that has really severely impacted our ability to provide those services and to get out into the community. Even now, while we're trying our best to go back, I think there is a hesitation. Before, one of the big things we used to do in Karachi, at least as part of the TB program, was these, community camps. On these mobile TB vans that we used to get out there and get people to just come out and get free screening. And there used to be camps in schools with teachers and students and households and so on. And I think one of the biggest things obviously has been impact is in our ability to do that. So I think, I completely see that it has taken COVID has taken the TB fight back a number of years, unfortunately, but I think it really just means that we need to re-strategize and I think maybe be innovative again in how we want to message and how we want to target groups, especially at the community level. As Carmen said, we can't stress enough how important it is to get out of the health facilities and into the communities in order to provide those services.
In Peru, we are working very hard with a person that had TB, and they organize in community organizations. We are working with three organizations, from I think close to 40 persons that had TB, and they are using in coordination with us the chatbots. Chatbots are very interesting program. The technology, we implement the technology in our intervention. In the chatbot, we can to elaborate the PHQ night tool, and this person that they are moving to the communities and they are asking to different persons if they are having problems, mental health problems. with TB or not TB, not necessarily is all for TB. And then remotely, one group of psychologists are provide different intervention. One of them is PM+, the another is psychological first aid, and another is grief therapy. And yeah, it's a big project that we are having, but it's so interesting. The numbers is too high. We screen close to 100,000 persons that are living in the community.
I can speak in Brazil, in Itaboraí, in that city, there was actually a very interesting change that happened because of COVID. Initially, there was a spike in case detection of TB cases because people with cough were coming to get tested for COVID, and they actually had TB. So COVID was a less stigmatized illness, and they were coming in to get tested. So there was an increase. That said, in terms of the provision of care, this health system is so overwhelmed that very little mental health treatment certainly is going on, and the TB care program is struggling given the burden.
Thank you. I think we have time for maybe one last question. So I just wanted to pose the question about, in terms of delivery, the pros and cons of individual-based counseling versus group setting, group counseling. I wonder if some of the panelists can talk about your experience with either of those.
So in Pakistan, we had tried group therapy for TB patients. And when we tried it in the facilities, there just wasn't an adequate space. Honestly, it really came down to something as simple as that, a challenge just not being able to have a space to bring people together on a continuous basis. Also, sometimes, for people in the community, often it's really the poorest people who have TB. And for them to come for these support group sessions on a regular basis, the transportation cost to do that was a barrier. And so it was, if they were aligned in such a way that they had to come back for their regular visit or to pick up the medications, that could work, but we were just not finding a group that could meet again and again. It was always new people, different faces, weren't being able to build that rapport that was needed for effective group therapy. At the community level, we tried it again. And again, the issue was just being able to get people who were really ill out of their homes to even just move 2 streets down to somebody else's home, or maybe 10 streets down, just move at some distance to get to a group session was just, it was just not happening. It was just something that was logistically and operationally a big challenge. So it wasn't working for us. What we have done now is try to set up community advisory groups for TB. And what that includes it's just not TB patients. There's either support, family, either a family member or a TB treatment coordinator or somebody else in the community who is part of that. And that group has been more successful because it has 1 or 2 TB patients, but a lot of the times it's not just TB patients. And so that community advisory group, the focus of course is on issues of stigma and getting community buy-in and so on, not necessarily mental health support only, but we have had more success with setting that up as opposed to group therapy.
Great, thank you. So we're actually out of time, so I think we should probably end the call and end the session now. I do want to thank all the panelists, all the speakers for taking out your time to share your amazing work with the rest of us. And special thanks also to Elisa Sanchez, Rachel Holland, and also Isha Parupudi. Elisa and Rachel are with the UC Irvine University Advancement, and Isha is with Columbia University. We really couldn't have put this event together without the support. So, and again, thank you to all the attendees for taking out your time. We posted our email in the chat box, so please stay in touch with us. We do have some other events planned in the near future. We really want to, there's clearly a lot of expertise within all the attendees as well, including, I think, Ian Walker, who posted a link to their work in Nepal. So we really want to create and foster a community of people who are committed to ending TB by addressing mental health. So please stay in touch with us, and thanks again to everybody.